I'm Courtney Crawford, a vitreoretinal surgeon with Star Retina. I wanted to share a vitreous opacity case with you using a small gauge vitrectomy cutter. This is a male patient with a visually significant posterior vitreous detachment with vitreous debris. Due to the central nature of his PVD, he does note vision impairment that affects his quality of life. The plan was for the patient to undergo treatment with a 27-gauge hypervit cutter. The 27-gauge vitrectomy system allows us to make scleral incisions that self-seal without the need for more tangential entry angle for trocar placement. The hypervit cutter allows a surgeon to safely and efficiently remove vitreous gel in a manner similar to the 25-gauge vitrectomy system. The 20,000 cut rate of the hypervit allows for rapid vitreous removal without compromising stability, resulting in minimal retinal movement. The stiffness of the 27-gauge hypervit cutter will remind the surgeon of the stiffness found with the 25-gauge cutter. Notice the ability to shave the peripheral vitreous gel safely despite the close proximity of the beveled cutter tip to the retinal surface. The light pipe of the 27-gauge system does cast a slightly less diffuse light beam, but the surgeon can compensate for this by both increasing the light pipe intensity and maintaining the light pipe more anteriorly in the eye. There are no unanimously accepted guidelines on when patients should be considered for vitrectomy for vitreous floaters. Since vitreous floaters do not significantly impede common clinical measures of visual function, such as visual acuity, contrast sensitivity measurement may be the most clinically relevant metric that can validate patient-reported visual impairment, and this has also correlated with improvement after intervention. Several studies have evaluated the use of small gauge vitrectomy used to treat symptomatic floaters. Seabag's group evaluated the outcomes of 25-gauge vitrectomy for symptomatic floaters in patients with a mean age of 59 years and at least 24 months of visual symptoms due to floaters. No posterior vitreous detachments were induced intraoperatively, and the anterior vitreous was left intact. Normalization of contrast sensitivity function occurred in each case as early as 1 week after surgery and persisted at 9 months. No patient developed retinal breaks, retinal detachments, endophthalmitis, intraocular hemorrhage, or glaucoma at mean follow-up time of 17.5 months. Lynn's group evaluated outcomes for 47 eyes of 47 fairly young patients with symptomatic floaters with a mean age of 34.7 years, with symptomatic floaters for a median time of 18 months, treated with 27-gauge pars plana vitrectomy. PVD was induced in only 22% of eyes without pre-existing PVD, and anterior vitreous was preserved in all 42 postoperative phakic eyes. The median best-corrected visual acuity was the same as that preoperatively, and no lens injury, vitreous or retinal hemorrhage, or iatrogenic retinal breaks occurred intraoperatively. In a study by Kahn's group evaluating posterior segment disease treated by 27-gauge vitrectomy, the 8 of 95 eyes treated for visual opacity symptoms had improvement in visual acuity and did not encounter intraoperative complications. What these studies have in common is that treating vitreous opacities using smaller gauge vitrectomy appears to have a minimal occurrence of intraoperative complications, even in cases when PVD is induced. The comparable experimental flow capability of the 27-gauge dual-blade hypervit compared to the predecessor single-blade 25-gauge advanced ultravit in addition to the decreased peak tractional forces in porcine vitreous, may favorably affect both efficiency and safety. I have recently begun using the 27 gauge Hypervit in my vitreous opacity cases, as well as other types of cases. It has provided me additional confidence with both its predictability and controllability. I hope this case provides some helpful information for you. Thanks for watching.